Thank you. It's a pleasure to be here. I have no financial disclosures. I do have one pharmaceutical disclosure, which is that I will be talking about off-label use of remifentanil for labor analgesia. The objectives for both nitrous oxide as well as remifentanil PCA, the talk will focus on really a little bit of the data on the efficacy of both, understanding the safety of both and how to maximize it, and then giving some guidance on how to implement these strategies safely as alternatives to neuraxial labor analgesia. So let's start with remifentanil. Okay. In the majority of centers in the US, both private and academic, remifentanil is primarily used for women who need an alternative for neuroaxial because of, say, low platelets or purposeful anticoagulation. Maybe they have a heart valve or a history of a PE, and that's primarily how it's used. This is different than nitrous, which is what we'll talk about in the second half. I'm going to guess most of you are quite familiar with remifentanil, but just for those who aren't, it's a very unique drug in that it has a very, not only rapid onset, but goes away quite quickly because of plasma esterases. It has a short context-sensitive half-life and a short respiratory depression half-life. This is just a graph of a variety of synthetic narcotics. You can see remifentanil along the bottom there. And the idea is it was a drug that was developed that you could run for a long period of time, and when you shut it off, it would go away as if you'd only run it for a matter of 10, 15 minutes. Okay. The purpose of remifentanil in labor analgesia is really for the fetus. The drug is chosen not so much for the mother, as you'll see when we talk about the safety of it, but it's more because that way when you give the last dose or shut the infusion off, it goes away within a rapid amount of time so that you don't have significant neonatal depression, and you can use it during the second stage of labor. What about pregnancy specific to remifentanil? So the placenta itself has nonspecific esterases that help break down remifentanil. Near birth, the fetal esterases are nearly fully developed, so you see the fetus metabolizing the remifentanil also. And consequently, as I alluded to before, if it's shut off just minutes before the delivery, you shouldn't have significant neonatal depression that needs intervention. As far as dosing, plasma concentrations in pregnancy are about half what you would see for the same weight individual in a non-pregnant state. This is due to the larger volume of distribution as well as the higher clearance rate. It does cross the placenta, but is metabolized by the fetus to a significant degree. How does remifentanil PCA for labor pain relief compared to fentanyl PCA? So this is a 2012 study. These are women who either requested not to have an epidural and were given an option of a remifentanil or fentanyl PCA, or they had contraindications to neuroaxial labor analgesia. I give the doses up there specifically not because this is necessarily the best regimen, but as you'll see, there's a whole variety out there, and so I just wanted you to know what was being used. The remifentanil, in this case, did have a little bit of a background infusion, and then Q2-minute boluses of a 1/4 mic per kilo. The fentanyl had no infusion and then had a range of boluses from 25 to 50 mics every few minutes. What they saw was not a significant decrease in pain scores between the groups. They had a little bit moderate pain relief with both methods of PCA. They did see significantly more transient maternal desaturation, oxygen desaturation with the remifentanil protocol, an odds ratio of 7. None of the women needed significant intervention in this study. And they saw more neonates in the fentanyl group requiring resuscitation after birth with an odds ratio of about 4. And this is what you're going to see in the literature. So if you choose a fentanyl PCA, it's a little more risk on the neonate needing resuscitation. If you choose a remifentanil approach, there's a higher rate of desaturation and possibility of hypoxia in the mother. How does remifentanil compare to epidural analgesia? So this is a multi-center study out of the Netherlands. People were enrolled in the study between 32 weeks and 42. They were randomized either to receive epidural analgesia or to receive a remifentanil PCA according to their protocol. What you found was slightly lower satisfaction scores with the remifentanil PCA. They were about 70% of what the epidural provided, and higher pain scores with the remifentanil, just slightly worse by about 30% than the epidural. So, in no way is this as good or better than an epidural, which is why most centers reserve it for people who can't have an epidural. But I think most telling is the conversion rate. So here the conversion rate in this study was 13%. The women were offered the option, no matter what group they went into, that if it wasn't working out for them, they could switch. And again, we see this theme of lower oxygen saturation in the remifentanil group. In this study, no one needed significant intervention, and overall maternal and neonatal outcomes were comparable. Okay. This is a recent review of the literature by Dr. Van de Velde and Dr. Carvalho, the second author on this paper too. And I put it up there not because I expect you to read it very well, but just to give you an idea of the huge variety of dosing schemes that are out there for remifentanil PCA for labor. You see that the bolus doses are around 40 mics on average, or if you assume an 80-kilo woman, about half a mic per kilo. Lockout times tend to range from about 1 to 3 minutes. As far as a background infusion rate, the majority of the studies did not use one, but a handful did, and half of those keep it quite low, somewhere up to about 0.05 mics per kilo per minute. Again, just like in the prior study I showed, I think one of the most telling things is the conversion to epidural from women who'd been in the remifentanil arms of these studies. And what I did was I took the liberty of graphing some of this data, and I looked at their dosing regimen and sort of figured out the maximum dose that they could possibly get in an hour, or as a rate in mics per kilo per minute. The size of the circle is the size of the remifentanil arm of the study, and the green dots are if they had a continuous background infusion. And so what's the point of this graph is that the majority of the studies, despite the different dosing regimens, the conversion rate seems to be right around 10 to 15%, certainly within 5 to 15%. So there is some significant efficacy to this, but it's balanced against concern for maternal desaturation. Okay. What about some of the data from the maternal-fetal transfer? This is a study from the late 90s, and the important part of it is down in the lower corner. You have umbilical vein maternal artery ratios showing that, and I should tell you about the study. So these were women undergoing cesarean section under epidural anesthesia, and then in the background they were given a remifentanil infusion of 0.1 mics per kilo per minute. And then at delivery, they did sampling not only of the maternal artery, but also the umbilical artery and vein to get these ratios. And you can see that in the time of standard C-section, the crossing of the placenta was about 88% of the maternal plasma levels, but that the fetus did a significant amount of metabolism because the uterine artery was only at about 30% of the uterine vein. Side effects of remifentanil on fetus and neonate. Very low incidence of fetal heart rate abnormalities, nothing that needs significant intervention. In the studies that are quoted here, no real notable effects on APGARs, cord gases, or need for neonatal resuscitation. There was one study, the top one there by Konefal in 2013, that looked for 24 hours after delivery and looked for any differences in heart rate, blood pressure, or SAT on the first day of life of the neonate, and there was no difference between fetuses that had had remifentanil and those that had not, for delivery. Side effects of Remi on the mother. So again, this theme of increased risk of maternal respiratory depression compared to use of epidural neuroaxial analgesia as well as fentanyl PCA. Remifentanil is sedating. There's some nausea and vomiting, itching like any narcotic, but no change in the rate of cesarean delivery. Okay. A couple years ago, there was a survey of US academic centers to see who was using remifentanil, and they just used the ACGME database of residencies. And of the academic centers that responded, which I think was around 84, 36% of them did have remifentanil available for labor analgesia. Most of them used it quite infrequently, and by infrequently we mean, say, 5 times a year. Some did it more than 10 times a year, but there was only a handful, and I think it was 3 or 4 out of these 84 that offered it regularly as an option. So again, the majority have used it quite infrequently. In this survey, they asked about events of respiratory depression on the mother, and there were a handful reported, and there were also an additional few reports of neonates needing some resuscitation with the remifentanil PCA. The point of this is that it's very important to have protocols in place, to have appropriate training and monitoring, and they're really key to safety of using this method of labor analgesia. Okay. So what are the recommendations for monitoring? So some things to think about are the benefit of having continuous, uninterrupted, one-to-one surveillance and monitoring. And I do agree it's incredibly important for use of this drug for labor analgesia. Having some monitor for ventilation. Capnography has been used, but someone just watching the mother continuously. Use of pulse oximetry. And initiation and titration of this drug should always be under the direct supervision of the obstetric anesthesiologist. This is not like some PCA that you would use for post-op analgesia for a C-section. This should be completely under the supervision of the anesthesiologist. Implementation, things to think about. Having a standardized order set. Having protocol and training of staff prior to the implementation, thinking about weight-based dosing as opposed to just standard boluses regardless of weight, starting low and titrating to effect, also knowing that with time and as the stages of labor change, you will probably need more, an increased amount of bolus, and the patient should be monitored frequently by the anesthesiologist, coming back, reassessing for the adequacy of the pain relief. Lockout rates, as we said, most are between 1 and 3 minutes. My experience has not been to do a basal rate, but I know they are done at academic centers. I believe it's probably safest to keep them quite low and not really go over about 0.05 mics per kilo per minute. Okay. We talked about the one-on-one supervision, having supplemental oxygen either being given or available as needed. Mistakes do happen. In the survey, a lot of the mistakes that occurred were just mislabeling of drugs or pharmacy making the incorrect concentration. And so because of that, neonatal resuscitation team should always be available when this is used. And then once delivery is completed, there's really no reason to use the remifentanil anymore. Remember, it's really for the fetus and neonate. And so if you have a laceration that needs to be repaired or something else where you need analgesia, stopping the Remi and switching to another method. Okay. So again, which patient should remifentanil be considered? So this is a recent editorial by Dr. Van de Velde. And just to quote him, although the remifentanil PCA is probably the best non-neuraxial strategy in terms of analgesic quality, there are significant patient safety hazards, and a real careful risk-benefit analysis does not support its routine use. So I agree, I don't advocate for it being an option for every woman for labor analgesia, and my experience is just only offering it to those who can't have it. Okay? Again, making a point for that one-on-one supervision with continuous observation really improves the safety of this method. Okay. So just as a curiosity, please raise your hand if you have remifentanil available at your institution as a method of labor analgesia, say for women who can't have neuroaxial. It looks like maybe around 15–20%. Okay. Does anyone offer it routinely? Okay. All right. Well, with that, we'll move on to nitrous oxide. Okay. So nitrous oxide started way back with Joseph Priestley. And I think originally it was more of sort of a party trick that was used at circuses and sideshows. And then with time, when we go from the late 1700s to present day, you see a variety of usage, but it was really in about the 1930s that it got used more and more, and that was because of the development of an apparatus that would allow it to be self-administered, both in the UK and in the US. Now in the US, in the 30s, it was mixed with other sedatives, benzodiazepines, opioids, things that would also cause respiratory depression, but it was used as a combination of twilight anesthesia for labor analgesia. And then with the advent of the epidural in the US, that sort of became the option of choice, where in Europe and Great Britain, because it was mainly delivered by midwives, they had not been mixing it with the other sedatives, and so it sort of stayed in hold in Australia, Great Britain, the Scandinavian countries, where it's used frequently, even to modern day. Those countries that I mentioned, it's used somewhere between 50 and 70% of all women giving birth still use nitrous as some component of their labor analgesia. In the US, although at UCSF we'd had it since the mid-80s, it's really since 2013 that the vast majority of centers in the US where it became available, and that was because nitrous oxide machines once again became available for purchase. In Europe and the UK, you can buy a pre-mix of oxygen and nitrous, but in the US that's not allowed. You have to have an apparatus that can blend. The reason nitrous is so appealing for labor analgesia is a lot of its properties, right? It's odorless, colorless, gives sort of minimal anesthetic potency, very low metabolism. It is, inhaled, and as I was doing this review, I found out you can buy a nitrous oxide drink, which then when I read the review, I noticed that it's also a component for boosting cars, so none of this should be confused. This is all delivered by inhalation. This is a nice systematic review in 2014, and really the point of it is despite nitrous being around for a really long time, especially in Europe and Scandinavia, we just don't have strong randomized controlled studies that go out, and further research is needed. And I think that's one of the efforts that is going on at many institutions who are now using it. Part of the reason is we really have not had general standardization in the studies that are there. There's different concentrations that were used. In the US now it's usually set at just a 50-50 blend, but previously or in other countries it can go up to 70% nitrous. The delivery method, whether it's continuous inhalation or intermittent, is different in the studies, different pain scoring systems, different comparison groups, whether it's to other opioids or neuroaxial or other agents which actually aren't even used anymore. And so because of that, it's really hard to do sort of a meta-analysis of its efficacy in the literature. So what I'm going to do is just present a few of the studies that are out there that are usually a little bit smaller. So this is a study that was completed in South Wales by Dr. Rosen, who's the individual in this front row here who trained me. And these were women who were breathing nitrous and for labor analgesia, and they just asked them to rate it. Did they get complete relief, considerable, slight, or none? And you can see that around 10% said they got complete relief that they needed for the labor analgesia. It was actually rated a little bit higher, I think, by the midwives who were saying, you know, good, excellent, adequate in the vast majority of cases. This is literature from Scandinavia, Primeps, and again, they just did a survey and looked at the method of pain relief from epidurals to nitrous to pethidine and had them rate it, very effective, some effect, or no effect. And you can see that nitrous is certainly not doing as well as the epidurals if we look at the very effective row, but it's not doing too bad compared to the opioids. And in multiparous women, again, not as good as the epidurals, but still pretty comparable to the opioids and maybe a little bit better than the Primeps. This was a study where women were randomized to have either inhaled 50% nitrous in oxygen or inhaled air, and they would ask them to give pain scores with each contraction, and then they would be randomized to the other group. And what you see is that there really is no significant difference in this study in the pain scores between use of the nitrous or the placebo. But the interesting fact was that after the study was over, a significant number of women wanted to know if they could continue using the nitrous despite not having a change in their pain score. And I think that's really where the benefit of nitrous is it's not really in lowering the pain, it's just sort of making it more tolerable. Okay. Another survey study of a variety of labor analgesic methods. I have a box around nitrous oxide there, and the laboring women as well as the midwives and obstetricians were asked to rate each method on a scale of 1 to 5, where 1 is something that they wouldn't want and 5 is something they definitely would like, and this was before they went into labor. And so you can see kind of where nitrous rates there, a little bit higher than epidurals, certainly below a support person. It also gives a little insight into some of the other methods of labor analgesia, from shower to heat pack to massage, which people were desiring more than epidurals. I also like the fact that it's, when we look at epidurals down at the bottom right, quite highly rated by the obstetricians as something they like in this study. The reason I bring up this study is I do think it's nice to have a match between what people would like for an option for labor analgesia and what is available. This is a more recent study by Richardson in 2017, and I just want to give you a little bit of a look at labor analgesia scores versus satisfaction. And so we sort of have 3 bars going from left to right. You have nitrous that was converted to a neuroaxial analgesia for labor, and then straight neuroaxial. And you can see as far as labor analgesia scores, where a higher percentage is more pain relief, that we're not doing as well with the nitrous as we are with epidurals or converting to epidurals. But when you go look at the satisfaction scores, regardless of the method, even the women that had just used nitrous, they rate it very, very highly for satisfaction, despite it not being that good for pain and analgesia. Okay. How does it affect epidural rates? This was just a before and after study out of 2016 where they implemented nitrous availability. And we really see no significant difference in the epidural rates in this study, meaning that the vast majority of these women did indeed go on to have an epidural, and it didn't appear to influence overall epidural use at this facility. Okay. How about predictors of conversion from using nitrous to neuroaxial? This is a study out of Stanford. and it's a retrospective look. Just to give you some baseline numbers, only about 3% of their total deliveries were using nitrous at the time, and when they looked at conversion rates, about 63% of the women who started with nitrous converted to needing an epidural for labor analgesia, and this is compared to a baseline 85% at their institution of women who chose epidural analgesia. The relative risk as far as predictors of who converted, having a labor induction was a 2-fold, and labor augmentation was 1.7, or also nearly a 2-fold relative risk of needing to convert. Okay. Maternal side effects, these are the most common maternal side effects: nausea, dizziness. There's a small percent of the population that get dysphoric with nitrous instead of it being sort of a relaxing, pleasant experience. It's the opposite of that, and the nice thing is you would just take away the mask and it'll go away within a few minutes. Transient unconsciousness really only becomes an issue if you start to mix other analgesics like opioids or benzodiazepines with it. Contraindications, fairly obvious: can't hold the mask, are already impaired, have had trauma, are unstable. Vitamin B12 deficiency can be affected. B12 is affected by nitrous, and so many centers have that as a contraindication. As far as effect on labor in the neonate, the short story is there really doesn't appear to be any by any measure. But with that said, this is an editorial by Takoa King, who was a nurse midwife at UCSF, and Cynthia Wong, who's now the chair of anesthesia at Iowa. And they just make the statement that it's probably impossible to perform human studies assessing, whether uterine exposure of nitrous during labor has adverse effects on the neonate. And that probably the thing we should be imparting to women when we offer them this choice is that we don't really have any data that it is bad, but we also don't have any great data, period, as far as long-term outcomes go regarding use of nitrous in labor. Okay? These are some statements from the European Society. They went through the animal and human evidence of nitrous oxide and found that there really isn't any reason to be changing clinical practice at this point in time, and they feel it's safe. And no evidence indicating the use, in a modern facility really increases any risk to either the patient or the provider. Okay. Well, what about the FDA? Dr. Flood yesterday went over the most recent FDA warnings for general anesthesia in pediatrics and in pregnancy. And she showed you this part that I'm going to show you here, which is all the general anesthetics that have been implicated as potentially being harmful. And you see what's missing from the list there is nitrous. Right? This was not an accident. I spoke to one of the committee members who was part of this FDA paper, and they said that in going through the evidence, there was no good evidence that nitrous as a sole agent caused any animal apoptosis in any study or neurocognitive deficit that they could see, as long as the concentration was less than 75%. And so consequently, they purposely left it off this list. For those of you who want to read more for that statement I just made, those two references down at the bottom are really excellent and go into great detail on all the nitrous studies that have been out there in animals and humans. Okay. This was a newsletter that came out a couple of years ago. I just put it up there because I think it's a really nice summary of sort of the pros and cons of nitrous, and it is something that I think should be an option for labor analgesia, as do many others at SOAP. And for those of you who are unfamiliar with it, I just have a couple of pictures of how it can be delivered. This is a picture from UCSF where it's actually piped into the wall with oxygen, and a blender can be hooked up with a scavenging system. There are also portable options that are made where you can use e-cylinders to blend it. and you just have to make sure that the tanks are appropriately pressurized and that you're getting an even blend to get that set 50-50 mixture of nitrous and oxygen. Logistics, it should be patient controlled. You don't want family members holding the face mask on. You want to educate the patient in how to use it. What we typically tell them is to start breathing it maybe a half a minute before the contraction, or continuously just breathe it as long as they want. You only want it to be the sole agent. You don't have to have an anesthesiologist present to be administering this, but I think that an anesthesiologist should be part of the protocol on the OB ward, because you don't want fentanyl being mixed with it. It changes the safety profile drastically. As we said, you can have it in wall connections or portable devices, and it is critical that you have a scavenging system present. As long as that's in place, the parts per million in the air in the labor rooms that have been looked at in a variety of academic settings now are well below the OSHA guidelines of 25 parts per million. But if you didn't have a scavenging system, say at a dental office, that's what you see in the literature where the parts per million get much higher. Okay. I just put this here as a reminder. One of the frequent things I've been asked is, do I ever see family members abusing it? This guy looks like he had a little nitrous. The answer is no. In many years of having this available, I've never seen any issues with family members abusing it. And I will finish with this slide by Takoa King, just saying that the story of how nitrous oxide is being reintroduced for the benefit of women in the U.S. is significant, and rediscovery can be as important, if not more important, than the original discovery. And I think it's really our responsibility to continue to do research in this area and make sure that it continues to be a safe option. Thanks.